Good evening, viewers. A very warm welcome to the yet another episode of 35th episode of ART Master Class. And in this season, we have been talking about the assisted reproductive technology, and various talks have been given by eminent personality. And today we have with us Dr. Jindal. Talking about Dr. Jindal, he is MS, DNB, MNAMS, FIAGES, IAGE. He is a chief consultant, laparoscopic surgeon, and andrologist, reproductive medicine specialist of Jindal Hospital. He is a scientific director of Dr. Madhu Jindal Memorial Test Tube Baby Center, Mirror. He is the vice chairman, Delhi ESAR, Delhi IAG. So he has many achievements, mentioning a few are genetic male giving birth to twins, 5 TESA ICSI babies born together, series of patients of TESE and micro TESE ICSI. He has also established a global ART forum as Center of Excellence. He has also contributed immensely in publications and presentations, contributing in 8 textbooks on fertility and over 200 national and international presentations. So his special interests are fertility enhancing and gynecological laparoscopic surgery, reproductive surgery, endolaparoscopic and microscopic andrology surgery, medical and laboratory andrology. And most importantly, by passion, he is an orator and a singer. So viewers, I'm sure all of us would love to hear Dr. Jindal singing in future if we get an opportunity. During the session, I would request our viewers to submit their queries in the chat box for Dr. Jindal to address. With this, I welcome you, sir, and thank you for joining us. The stage is yours.
Thank you very much. Thank you very much for the kind introduction. And I speak on a lot of things, but male fertility is something which I love to talk about because of two reasons. I'll share something interesting about myself. I was a postgraduate in Maulana Azad Medical College, where the urology and andrology department was a part of the general surgery department. So we had a very famous professor, Professor RCM Kaza, who used to be doing microsurgery, which means in those days it used to be a lot of vasovasal epididymis, anastomosis. And these were all those people who, from the time of emergency, were vasectomized. So during that time, also a lot of techniques of vasoepididymal anastomosis were developed. And this is 1991. So the interesting thing was that though these surgeries were done, pregnancy rates were very low. And sometimes after 2.5 hours, when a few sperms were got, I still remember, we all wondered what to do with these sperms. There was nothing we could have done. And we always used to wonder, there's such few sperms, can something be done to get a pregnancy? And this was 1991. And this was how I was introduced during post-graduation to surgical and medical andrology. But there was no attachment of any ART. So it was a beautiful science, but incomplete. And as time developed on, started doing laparoscopic surgery, started doing laparoscopic gynecology, laparoscopic fertility surgery. Then came a time when came ICSI. And intracytoplasmic sperm injection was something like magic and the biggest blessing to these few sperms. So all those dots got connected together. And came a time when, 70% of men who are infertile can have their own children. In fact, if you consider not azoospermics only, the rest of the men, it could go up to 90% of men can have their own children. So I thought I might as well formulate a program in which I could talk about concepts which need to be known by every gynecologist of male fertility, because men contribute about 50% of infertility towards the couple. And most of the time, these males are ignored, they're not looked after. So I've made a presentation, though I wanted to split it into 4 parts, but now I'm splitting it into 2 parts. So today, I will speak about examination, investigations, special investigations, and an interpretation of those investigations, which should make it something which every gynecologist should understand. And this is the purpose of today's program. So I would begin now with my slides. And of course, there is एंड में आई एम गोइंग टू स्पीक अबाउट मैं आपको एक शेर सुनाऊंगा और वो शेर आपको वो सुनाऊंगा जो हालत मेल फर्टिलिटी के मरीज की होती है विच विल बी इन द एंड सो आई विल बिगिन द प्रेजेंटेशन नाउ एंड आई विल बिगिन द प्रेजेंटेशन विद I'll begin the presentation which today I'm going to speak about male infertility from a gynecologist's perspective, part 1. So, the key concepts which I plan to discuss today are that the sperm count is going down over the century. Semen analysis, the way it is today in 2020, an interpretation of that. New diagnostic tests, the way they are. I will be talking about a few areas which have developed newly, and I'm going to talk about a few areas which need to be developed in the future, but that I'll do in part 2, not in this part. So the first and the most important thing is the examination of the male. Most of the people ignore the examination of the male, but the examination of the male tells us everything when we have to examine the testes, the epididymis, need to examine the full epididymis, and I have also put in slides of examination and ultrasound together to make a small presentation where people could understand. So while we do examination of the patient, this needs to be done for every patient. And in case we plan to do an ultrasound of the patient, this normally is done by a high frequency transducer and in the transverse and longitudinal planes. When we examine we examine with an orchidometer to know the volume of the testes. And the normal volume of the testes could be 15 to 20 cc. And whenever there's non-obstructive azoospermia, it's less. And when there is obstructive azoospermia, it could be the same, or probably it could be a bit higher. Now, what are the indications of a scrotal ultrasound? You don't do a scrotal ultrasound in every patient. You only do an examination in every patient. And this I want to highlight because a lot of times people think that ultrasound is the examination or sell the patient to the ultrasonologist, which actually should not be done. But the indications would be if there are absent testes, if the testes are not palpable, if there is an ectopic location and an enlarged testis is present, if there's a testicular tumor, if there are abnormalities associated with obstruction, and if there's a mediastinal cyst. In inflammatory conditions, you could do it. Epidermal abnormalities, you could do it. And of course, to confirm, in varicoceles, you could go ahead for an ultrasound. Now, when you examine an epididymis, as you can see over here, has 3 areas: the head, the body, and the tail. So these 3 need to be examined. You can see the epididymal head over here. You can see the epididymal body, and this is the tail. So these 3 need to be examined because by the fullness of these in an azoospermic, you can judge whether it is an obstructive azoospermia or a non-obstructive azoospermia. And you can also judge which is the site from where you would like to do a retrieval. Now, this was a patient of bilateral of azoospermia, and you need to examine bilaterally in this patient what is the status. And this patient had a congenital absence of the vas. So you can see over here, the epididymal head in ultrasound is full. And since I do sonology as well in these patients myself, so I'm very, very clear and I get a fantastic idea with the examination and ultrasonology that what is it exactly that I would be able to get in the whole, from where exactly will I be able to get sperms in azoospermia. You need to examine the vas. The reason is you feel it like a cord, and that's most important because in case there is an absence which you can see by examination, you would understand the reason for azoospermia. Ultrasound shows a cord beautifully. You can see the cord over here beautifully. This is an amazing investigation to see the cord, but the gold standard till today is the fingers. You need to examine this spermatic cord to see if there is any funiculitis, to see if there is any swelling, to see if there is any inflammation or pain. And of course, a varicocele needs to be examined when the patient is standing up. You need to examine the cord, and then you have to ask the patient to do a Valsalva maneuver. And during this time, by physical examination itself, you can know whether the patient has varicocele or not. Now, I'll just show you this ultrasound. Over here, you can see the dilated veins. You can see the flow and also the reversal of flow. This is a beautiful video of a patient during Valsalva maneuver. You can see very well over here that this was when the patient underwent, when we measured it without the Valsalva, and then we measured this with the Valsalva. And you can judge even by a 2D ultrasound that the patient has a varicocele. Now, what are the indications of color Doppler in varicocele evaluation? You do not need it as the routine. Routine is clinical examination, but you need it where there is a suspected case of varicocele to confirm grade 2 and 3, where there's difficulty in evaluation because the man is big, obese, scrotum is tight, there's a thick skin, or the patient has a hydrocele, or where you would like to evaluate the contralateral testes for the presence of subclinical varicocele before a varicocele correction. This is the indication. Transrectal ultrasound for seminal, vesicle, and prostate, most important. I have a small video over here to show to you how it is done. And you can also see over here that if the seminal vesicle is more than 25 millimeter in length, and if it is hypoplastic, and if less than 25, more than 16, or it is atrophic, is less than 16. So you can see over here, you can see beautifully over here the seminal vesicle, and the same probe which is used for transvaginal sonography is the one which is used for transrectal sonography. So you can see over here, there is calcification which is present in the ejaculatory duct, and you can also see the dilatation of the vas deferens. So there is a obstruction and calcification, which could also go towards tuberculosis in this patient. This calcification, once again, within the ejaculatory duct with dilatation of the vas deferens proximally. So, transrectal ultrasonography, I just wanted to put in the recommendation that transrectal ultrasonography is indicated in azoospermic patients with palpable VAS and low ejaculate volumes to determine if the ejaculatory duct obstruction exists. And some experts recommend transrectal ultrasonography for oligospermic patients with low volume ejaculates, palpable VAS, and normal testicular size to determine if partial ejaculatory duct obstruction is present. So, whenever the volume is low, and if you can palpate both the VAS and in a few oligospermic patients too, transrectal ultrasonography will tell you if there is any ejaculatory duct obstruction. So now let's come up to the most important thing which people may think is dry, but it is not dry. It is the most important investigation. And if for the male there is one investigation which is important, it is the seminal analysis. So now let us understand that WHO has come up with new guidelines, not now, but WHO came up with these guidelines in 2010. And if you look at it now, the volume is 1.5 ml, semen count is 15 million, total sperm count 39, total motility more than 40%, progressive motility more than 32%, vitality more than 58%, morphology more than 44%, and leukocyte count less than 1 million. Now let's understand four parameters in this. The first and the most important thing is the count. So the count today, as earlier used to be at the time when we were studying, 60 million is now 15 million. I'll also tell you how this has been come to. The second thing and the most important thing is, you know what is the most important parameter to judge fertility? Progressive motility. So, if there is a man who even has a lower sperm count but good progressive motility, his fertility potential is better. So, one particular area, the judgment of which is important and enhances fertility, is the progressive motility. The third important thing for us to understand is the morphology. Now, you may have seen a lot of reports which come as normal 40%, abnormal 60%. It is not that in those reports now, if it is only 4%, it is fine. No. This is by strict Kruger criteria. I'll tell you what it is. And of course, the leukocyte count needs to be less than 1 million, but we need to be sure they're not round cells by staining them, which is known as a peroxidase staining. So now what is the problem with the WHO reference value? It was done in USA, UK, Norway, Finland, Denmark, France, Australia, but not done in Asia at all. And we have not been a part of this WHO, so it does not actually represent our population. In fact, a large population, whether it's Africa, South America, or the Asia, has been left out. So it is of a different population altogether, number one. The second issue is it was a different method of doing it by a different QC standard. And there was adoption of strict criteria for morphology for which the slide needs to be stained and 100 sperms need to be examined, and the exact dimensions and the way the sperm is form of the sperm is important to call it normal. And it takes about 15 to 20 minutes to do a semen analysis if this is done by an expert. And therefore, Kruger's criteria is not followed at most of the laboratories. And it's important to follow the Kruger's criteria by the WHO manual. The second thing which was there is that when these tests were done by WHO, they only took a single specimen. They did not take two specimens. And what they did was that in the whole area and in the whole data which they got, they calculated what is the percentage of the fathers or the recent fathers and their time to pregnancy. So that's the way it is, but still, it is today the official WHO which is followed. So let's understand about Kruger's criteria. So now in Kruger's criteria, you need to measure. This measurement is done where you find that the head is 5 to 6 microns, the width is 2.5 to 3.5 microns, the midpiece is 1.5 times the head, and the tail is about 45 microns. If you see over here in this slide, you would realize that this is an abnormal head, while this has a tail defect. And in these slides, if you look at it, you would find that probably this sperm has 40 to 70% of the acrosome in the head, which is important. The staining of the acrosome is different from the head, and the midpiece, if you calculate over here, needs to be 1.5 times the head. All these things together, if there is a sperm which is borderline, it is considered to be abnormal. So this is Kruger's criteria, which every person should understand today. Now, new WHO standard, what is the interpretation? So like this is a report. So you could see over here that the fifth percentile in the reference limit is 1.5. So 3.5 is normal. The count is 10, while it should have been 15. 35, while it should be 39, but the motility is 70%. And the progressive motility is 54%, while it should have been 32. It is normal, more than 32. The vitality is good, normal forms are good. So the interpretation of a semen, it is not like mm, you can have a baby, you can't have a baby. No, it is just an interpretation which is to be done in toto. So if you realize over here, there's a 10 million count, but the progressive motility and the total motility is higher. The total count is about 35. You need to keep all these parameters in mind to understand the fertility status of the male. Now, there is no accurate to discriminate infertile and fertile men, as I have said. So it goes much beyond a simple semen analysis, a physical examination, laboratory testing, and the function testing of the sperm. I'll talk to you about that. So now what are the clinical implications which you have of the semen analysis? So if there is a low volume or absent fructose, it could be vasaplasia, there could be ejaculatory duct obstruction, there could be chronic seminal vesiculitis with fibrosis, a hypoplastic seminal vesicle, partial retrograde, fructose will be positive, and urethral pouch stricture, fructose would be positive. So all these things will need to a low volume. So I'm talking of the semen analysis, so low volume. Next is impaired motility. If the motility is less, it could be associated with oligozoospermia, naturally, idiopathic. Infections can lead to impaired motility, and it could be because of antibodies. Now, next comes agglutination. Now, agglutination is normally because of infections, antibodies, and it can be idiopathic. So, whenever you have agglutination, you need to see if the leukocyte count is normal or not. You need to do a peroxidase test to be sure they are not immature sperms, they are leukocytes. And if the leukocyte count is high and agglutination is present, infection needs to be treated. Now, if there is altered liquefaction or viscosity, it could have been a past or present infection, or it can be idiopathic. Now, supposing there is total asthenozoospermia, which means the motility is not there. It can be either with viable sperms. See, you check the immotile sperms do not mean that they are not viable. So you do a vitality test. And in the vitality test, when you stain with eosin, in case the stain is picked up, you then judge that despite immotility, the sperms could be viable. And if sperms are viable and they are not moving, it could be a microtubular defect in the sperm tail or Cartaginer syndrome. But in case they are non-viable, then it would be necrozoospermia. You also need to do a Hodge test at times by which you can judge if there is a viable sperm among these non-motile, which you could pick up and use for ICSI. And you can also use something known as a sperm flexibility test to judge in ICSI. But the most important thing is you need to rule out any kind of collection error. Just understand, if a man passes on even 2 or 3 drops of urine into semen, the sperms would be dead and would be immotile. So you need to rule out any kind of a collection error. Now, if there is it can be because of a varicocele. It could be because of some gonadotoxic effect, some recent illness, relative gonadotrophin deficiency, and a partial obstruction. Now, if there are large number of abnormal sperms, it could be because of Kruger's criteria not being understood well. You need to go to a specialty lab to get the testing done. An ordinary lab will not be able to give you that. It could be because of some kind of a gonadotoxin exposure, or it can be an intrinsic defect. Now, I've tried to make a small, I would say, flowchart because I love understanding things by flowchart and explaining by flowcharts. So, in case the volume is can be low or it can be high, the viscosity could be incorrect, it could be high. You need to do a PCT if the viscosity is high to see if you have a normal PCT or an abnormal PCT. You could have an abnormal morphology. And in the abnormal morphology, you'd like to see if there is a stress, remove stress from the source. If there are any kind of gonadotoxins which are there phenomenally today, there could be drugs, there could be cigarette smoking, there could be any type of thing being taken in the food, there could be chemicals, there could be radiation, remove from the source. If there is a varicocele, do a varicocelectomy, which would be microscopic varicocelectomy. And if they're idiopathic, you repeat the semen sample for sure. Now, there could be a problem with the sperm density, oligospermia or polyzoospermia, and there could be a problem with the motility and the forward progression. If this exists and agglutination is there, look for anti-sperm antibodies. And if there is still asthenozoospermia or asthenospermia, look for genital gland infections, varicocele, or some idiopathic cause. Now comes an important thing. What is the additional sperm testing? So you could do a vital staining, anti-sperm antibodies, semen fructose, peroxidase staining, semen culture, biochemical analysis of the semen. And there's some specialized tests like hypoosmotic swelling test, sperm penetration test, human zona pellucida binding test. This is not done. And of course, CASA is done. But all these things together, if I sit down now to speak about them, it could be another hour or even more, I think 2 or 3 hours about only these tests. But I'd like to just cover the important aspects which are practically useful. So one is the FSH LH testosterone. So if the FSH is low, LH is low, and testosterone is low, it means that the hypothalamus is not making it, and it is what is known as a hypothalamic pituitary axis, and it could be a hypogonotrophic hypogonadism. In case you have an FSH which is high, an LH which is high, low or normal testosterone, this would suggest a testicular failure or a non-obstructive azoospermia. And if you have a condition in which you have everything normal and still the patient has an azoospermia, this could be obstructive. So whenever you have a place like this, but what are the tests which you should get done? You should get done testosterone FSH always in any patient who has a sperm count less than 10 million. However, in a few cases, LH and E2 may also be required, and E2 is especially required in obese men to see if the testicular estrogen ratio is disturbed. Because if that is disturbed, then the drug treatment will be dependent on it, which I'm going to speak tomorrow in the medical treatment. Now, scrotal ultrasound I've spoken about. Postcoital test, which used to be a very old test, which is not done by a lot of people. At times you need to do it. And you need to do it in case there is agglutination to see if these sperms are moving up. And number two, if you feel there is a sexual dysfunction and the couple is not talking about it, then a PCT may be required. Now, the threshold values, so this is something which I've spoken about semen analysis, though we can talk hours about it, but I'll go on to something for us to understand that this report does not tell us about subfertility per se. And a lot of caution needs to be used while interpretation of the results. And more important is for us to understand the functional capacity of the sperm. I always tell my patients, if there is a unit of the army of 100 people, 100 soldiers, then the unit is only 100 soldiers if you have 100 soldiers. If you have 30 soldiers with 70 civilians, the number is 100, but the fighting soldiers are only 30. So the number may be fine, but if the functional capacity of the sperms is not correct, pregnancy will not take place. So this is something which is very important for us to understand. And I will only talk to you today about the relevant sperm function tests. So I'll talk about 3 tests which are doable, which are being done, which we do, interpret and teach patients and treat patients. So the first is sperm DNA integrity. The second is reactive oxygen species. And the third is Y chromosome microdeletion screening. And the research should and is being done to focus on the efforts of sperm function where the testes is not fiddled with, and we could do it on the sperms itself. So there have been some recent developments. So there have been mainly 3 recent developments. Number one, sperm function testing. Number two, microsurgery. Number three, genetic diagnosis. So three testings are there: sperm function testing, microsurgery, and genetic diagnosis. So I'll speak about sperm function test. I'll talk about a little bit about microsurgery, and I'll talk about genetic diagnosis and the future. Uh, a little bit of genetic diagnosis tomorrow. So now, sperm DNA integrity. Now let's understand a few things about it. The background is that normal sperm chromatin paternal is needed for paternal genetic transmission. So the head is tight, it contains chromatin, there is very little cytoplasm. The chances of destruction of this DNA is very high by oxidation, and if there is fragmentation, it would lead to a few situations. What would it do? It could lead to unexplained infertility. It could lead to recurrent pregnancy loss. It could lead to poor outcomes in IUI and IVF. Now, what's the principle? The principle is quantification of sperm DNA breaks, and the specimen for this is semen, which means in semen spermatozoa. The techniques which are used, the most standard technique used all over the world is tunnel and comet. But a technique which can be used in laboratories normally is the halo test, which gives us a fair idea about the DNA fragmentation. So let's look at some interpretations of major studies which have been done in the world. So where they have seen the live birth rates by intrauterine insemination in a normal specimen in the laboratory, if the DNA fragmentation is fine, is about 19%. But if the DNA fragmentation is elevated, it is about 1.5% only. Now, whenever there is DNA fragmentation and you do an IVF, there's 26% pregnancy, while it enhances to 42% with ICSI. Why? Because the cytoplasm of the egg repairs the DNA of the sperm. And the younger the egg, the better is going to be the, um, I would say, the better would be the way it's going to be repaired. So I'll just take a minute. Yeah, thank you. I'll just take 1 minute. Sorry, there was just some patient about, I just had to give some instructions about some case. Now, sperm DNA fragmentation and miscarriage. Now, let's understand one small thing. This is a large study, a very big meta-analysis. And the technique of DNA was done over here, tunnel and comet, which is the standard. And there was a significant increase in miscarriages in patients where there was sperm DNA damage. Now, I was talking about the halo test. So the intact DNA shows halos, as you can see over here. And these fragmented shows that the DNA is degraded. And normally what is considered as 30% is considered the, I would say the 30% is considered the cutoff. And this cutoff gives us an idea by the quantification whether there is excessive DNA fragmentation or not. So I've spoken about DNA fragmentation. Where normally will I get it tested? I will get it tested where there's a repeated failure of IUIs, IVFs, recurrent pregnancy failures, or in a patient of unexplained infertility for a long time despite the semen parameter being normal. Or In case the patient has been exposed to gonadotoxins, paternal aging is more, the patient has been a smoker for long, or the patient does have a varicocele with a normal sperm count. So these are the patients in whom doing a DNA fragmentation is going to help us. Next, we come to Y chromosome microdeletion. Now, in spermatogenic failure, you would find that there could be a situation where there is Y chromosome microdeletion. So, normally a PCR is done of the long arm of the Y chromosome, done from peripheral blood. You would do it in severe oligospermia or non obstructive azoospermia. And the clinical significance is that it has a good predictive value for sperm retrieval. Now, as you can see over here, in case it is in the AZFA area, there is no retrievable sperm. If AZFB area, no retrievable sperm. But if it is in the AFC area, sperm can be retrieved in 70% of the cases. Now, I would just touch in azoospermia briefly. And I would touch in azoospermia briefly because in the medical tomorrow, there is so much which I need to come across to you of how to treat these people medically. I would just like you to understand a little bit about azoospermia. So, azoospermia can be of two types: obstructive, non obstructive. And we all know that about 1 to 3% of males are azoospermic. 1 to 3%. In fact, most of the patients who come to me who have azoospermia, they are depressed. They normally don't want to tell their wives that they are azoospermic. They feel as if there is something phenomenally wrong with them. Their self esteem is down. So I need to counsel them. And I will briefly talk about counseling. And when I need to counsel them, I counsel them about the fact that about 1 to 3% of people are azoospermic. And no man who's azoospermic tells another human being that he's azoospermic. So you never know. Your best friend may be azoospermic too. One. Number two, 70% of azoospermic men can have their own children. And this is what I always was telling you. When we used to find two or three sperms and did not know what to do, till ICSI came in. So ICSI has done magic for these men. And azoospermia contributes about 10 to 15% of male infertility. So it's of two types: obstructive and non obstructive. And this can be, as you can see over here, it can be pretesticular, which means the FSH and LH are down, hypogonotrophic hypogonadism, or it could be testicular, which means in this testes, sperms are not being made, or it can be post-testicular, where the whole area, the sperms are being made, but they are getting blocked, which means an obstructive azoospermia. So now please understand, if it is hypogonotrophic hypogonadism or pretesticular, I would need to give drugs which can start the testes. If it is testicular, I need to open this up to look for sperms. And if it is post-testicular where it is blocked, either I would have to repair the block, and if not repairable, I need to retrieve sperms either from the epididymis or from the testes and use them for ICSI. So this diagram per se gives us a fair idea of what we need to do. So an obstructive azoospermia will have a normal size testes or endocrinal profile. It could be a mechanical blockage. The non-obstructive azoospermia will have spermatogenic failure, FSH-LH high, testosterone low or nil, testes small. And a hypogonotrophic hypogonadism will have FSH-LH low, low testes, low testosterone, and poor virilization. So in them, there is disruption. In this, you would give medical treatment, which I will talk to you about tomorrow. And I will give you a small overview of what needs to be done. How do you interpret azoospermia? Another clinical diagnosis which I had to talk about. So, physically, you examine. In case bilaterally the vas are palpable, there is a possibility of ejaculatory duct obstruction. You would like to do a transrectal sonography. And if this transrectal sonography shows us a blockage, you would like to do either a laser or a TUR incision of the ejaculatory duct so that sperms could come out. If there is an absent or bilaterally absent on palpable, congenital absence of vas, well, you need to do an assay of CFTR, cystic fibrosis. And once you do an analysis, you also need to do this analysis on the wife because you need to see if the wife is a carrier or not. If she is a carrier and the man has this problem, doing an ICSI is going to create a problem because the babies could have um, uh, uh, cystic fibrosis. So, in case the wife is not a carrier, then you could do a surgical sperm harvesting, and then you could do different methods by which they could be harvested for an ICSI. Now, if there is a normal volume anisospermia and the volume is more than 1 ml and the pH is more than 7, take history, do a physical examination. It could be with a normal FSH or a high or a low FSH. If the size is normal and the FSH is normal, suggestive of obstructive azoospermia, see if reconstructive surgery can be done. If it cannot be done, please go ahead and do a surgical sperm harvesting. If it is non-obstructive azoospermia, small testes, low FSH, low LH, low testosterone, hypogonotrophic hypogonadism. Nowadays, I get a lot of patients with low FSH, low LH, and high testosterone. Now, these guys come with big bodies to your clinic, and after coming to your clinic, they normally say everything is fine, but there is impotence, and along with impotence, there could be azoospermia. So this is anabolic steroid. I've written use, but it's misuse, and that's the reason why it happens. And you need to stop all these hormones, wait for about 6 months, get the FSH, LH, and testosterone done again, and then plan what you want to do. Next, you have FSH, LH, and testosterone, where the FSH is high, LH could be normal or low, and could be high or low, or testosterone could be high or low. Non-obstructive azoospermia, do a Y chromosome microdeletion, do a karyotyping in these patients, and then go ahead for the surgical sperm retrieval. So we've had this, I've made these two charts which I want to show you, and I'm sure it's a fair idea which you have judged from this. So I'll talk to you about hypogonotrophic. Now I'll just tell you. So it's a very interesting patient whom I had of hypogonotrophic hypogonadism 14 years back. Now I have a very large series of these patients. So very rich patient. And the mother came to me and said that I know somebody whose reports are this. And from where can I buy the most expensive sperm? So I asked her, why do you want to buy the most expensive sperm? So she said, because I have been told that my son can never have a child with his own sperm. So I said, probably, I don't know the most expensive, but the most appropriate sperm would be his own sperm. So this was about 14 years back when they came to us, and I started him on the dosage of FSH and LH. And sperms appeared in the 14th week. We did an ICSI in the first cycle, didn't get pregnant. In the second cycle, thinking that we did not know what will happen, we transferred four embryos, which we don't normally, and we don't do it at all, in fact. And she had quadruplets. So did a fetal reduction and gave birth to these two babies, beautiful babies. So this is 14 years back how I and my wife looked like. So after that, we've had a large series of these patients of hypogonotrophic hypogonadism. And let me tell you one thing. At times, the sperm count is so good that they could actually naturally conceive. So if somebody enters your clinic who doesn't have facial hair, or what I say is bandi nua banda lagta hai, and if he's azoospermic, if his testes are small, get all the tests done, and you could treat him medically to get sperms in case he's a hypogonotrophic hypogonadism. So these are different techniques which we use. We use PISA, MISA, TISA, TISE, micro-TISE. So I will talk to you shortly about it. Now, PISA is when you take the sperms out of the epididymis. So what you use is normally a 24 gauge or a 21 gauge needle into the epididymis to take out these sperms using a 5 to 10 ml syringe. TISA is when you aspirate from the testes and you use a 20 ml syringe, and you normally use a 16 gauge needle or a 19 gauge needle. And TISA is when you take out a piece to check, and you could also take something out from an epididymal cyst if it is present by a needle. Now, this is the video of a PISA using a 24 gauge. You can see it is the, no, I'm using a BD syringe over here with an insulin syringe and a 24 gauge needle. Now, this does not retrieve a lot of times, but what you need to do is, in case the epididymis is full, you need to catch the fullest area, put the needle in, give a suction, try to get these sperms out. See this fluid. And if this fluid has sperms, well, the job is done. Now, this is what it looks like, a full epididymis. I'm just trying to show you this, that this look, if you see, you know that you're going to get sperms from the epididymis. You can open them surgically, and do a MESA. Now, the advantage of a MESA is that you get a better amount of sperms, good amount of sperms, which you can freeze. Even with a PISA, you can freeze. And number two, you do not damage the epididymis. See, whenever you put in a needle in the epididymis, you break the tubules. And this means that the integrity of those tubules is broken. So if there were ever any chance, like at times it takes place in non-obstructive azoospermia, that the patient may get sperms, you've broken the tubules, so the channel is broken. So that's why MESA becomes important. Now, you could do a percutaneous epididymal aspiration with a 21 gauge butterfly with a 5 or 10 ml syringe in case you cannot do it with a 24 gauge needle and a BD syringe. And in a lot of patients, this is a better option, that you put in the pressure, you clamp, you remove the needle, and see if sperms are present. So retrieval is done in up to 95% of people. And this is a beautiful paper by Sandros. Of course, the brilliant man always comes up with fantastic literature and training. And there's so much which is to learn from Professor Sandro, Dr. Sandro. So in this paper, he shows very clearly that the chances of sperm retrieval is up to 100% by PISA in obstructive azoospermia, post-infection closure, and not PISA exactly, but percutaneous, it could be a TISA as well. You could retrieve sperms in so many. And the ICSI outcome using ejaculated versus surgically retrieved sperms is about the same in terms of fertilization rate, pregnancy, miscarriages. So it's, if you ask me, it equals any kind of ejaculated sperm. So the results in obstructive azoospermia are very good because most of the times the woman is fine and she's just waiting for the embryo. So in obstructive azoospermia, the chances of having a baby with a retrieved sperms are excellent. So if there's obstructive azoospermia, please do not offer any patient a donor sperm. A retrieved sperm is as good as an ejaculated sperm. Now, these are the results, and the results, as you can see, when compared with donor sperms, are excellent. Now, let's come to non obstructive azoospermia. Non obstructive azoospermia is when there are few pockets which are present where spermatogenesis takes place. So, this is the testes, and in this testes, you have few pockets of spermatogenesis. This is testicular failure. So these are the places from where you need to take out sperms. So in case you do a testicular biopsy, the simplest way to do it is through a window technique where you just take out tissue. This you would do in an obstructive azoospermia or hypospermatogenesis where you are not where you feel spermatogenesis is taking place and you would not like to open up the whole testicle. Now, you could do multiple biopsies. This is a procedure which is done a lot of times if you do not do a micro TC. So, what is done is that you open up the testes. This patient had been operated before and he had a very adherent tunica. So, once the testis is opened, multiple biopsies are taken from 8 places, and these multiple biopsies are then sent so as to get some sperms from at least one. This normally is done in non-obstructive azoospermia if you are not doing a micro TC. Micro TC is definitely a better procedure. Now, how do you prepare a testicular or epididymal spermatozoa? So this is the tissue which is there. So this tissue is teased and stripped. So basically what happens is you strip them to open up the tubules. And by this squeezing, which is done by the needle, you would realize that a homogenate is made, and from this homogenate itself, you're able to get sperms out. Now, needle mapping is something which I do, and I do this needle mapping before I go ahead for a micro TC. And what I do in this, and what we do in this is you do multiple site aspirations. So you take about 16 places, and these 16 places, after taking these 16 places, you put in a needle, use a 20 ml syringe, give pressure, and once the pressure has been done, whatever material we get in the needle would be placed on one of the dots. And if case sperms are got from this area, we then would enter this area to take out a specimen. At times when we are doing a TISA mapping of the testes, we've opened the testes, and after opening the testes, we see 16 areas. And in these 16 areas, before a micro TISA, we would put in a needle, give a suction, and while removing this and pulling it out, normally there would be one area which subtubules would come out. We could then just pull out this tubule and get a reasonable amount of testicular tissue. Now, I'll come to micro TSA. So, in micro TSA, what happens is that we need to understand about micro TSA is that we would open up the testicle, and after opening up the testicle, we would like to see under the microscope if there is any area where there are tubules which are different, or tubules which are swollen, and tubules which appear to have spermatogenesis. You would take out these tubules, and these are the tubules which would be then sent to the laboratory. You would go into a deeper plane and into different deeper planes. Once you've gone and you've taken out tubules from different areas, this is the way a testis would look like when you start closing it and close back beautifully. So you would have in these small tubes what you have retrieved, and sperms would be taken out from this. This is how it would appear to be under a microscope if you see. So testicular sperm extraction, as you see over here, this is a specimen in which it has been cleaned, it has been stripped, and you can see over here that we're wanting to get a sperm, and there is one sperm which is lying over here, which we're wanting to pick up, and there is the sperm. So you got the sperm in vision, and after we have taken the sperm into the ICSI pipette, there you have the sperm. This is the sperm. You would pick it up, go ahead and ICSI. So it becomes a beautiful procedure for azoospermics. So, well, the key messages would be obstructive azoospermia, fantastic. It is independent of obstructive etiology, chances are very good, independent of retrieval technique, independent of sperm source, and the results of this are just fantastic. And well, in non-obstructive azoospermia, of course, the retrieval rates are about 50%. It's labor intensive, and it depends on the histology. Y chromosome microdeletion, micro TSA is the best, and reproductive potential, of course, is lower in obstructive azoospermia than non-obstructive azoospermia. I would thank you all very much. I have tried to put in a lot of things together for the part one to be understood, and I would love to answer any questions if they are there. And thank you very much for the kind listening. And I really think we've had this program for about an hour now. It's a 1 hour, 4 minutes. That's fantastic. Yes, please.
Absolutely, sir. Thank you so much for the wonderful session, sir. I'm sure our viewers have benefited a lot, and which shows that they have a lot of questions. With your permission, sir, I would like to ask a few questions.
Yes, please.
So we have a question which is from Dr. Trupti. If ICSI done an embryos arrest during growth, DFI is indicated or not?
See, just understand one small thing. Are you doing an ICSI for an obstructive azoospermia, non-obstructive azoospermia, or are you doing an ICSI regularly otherwise? So please understand, ICSI is an answer for DFI. If there is a patient whom you get of recurrent pregnancy failures, poor IUI results, poor IVF results, then the answer in front of you is to do an ICSI. Now, if you've done an ICSI and there is an embryo arrest, then the answer in itself for a poor DFI is ICSI. So you've done an ICSI for these patients. Apart from this, look for something else. So your actually ICSI becomes a treatment for a bad DFI. Because what happens is if the egg is good, a sperm, normal looking sperm. See, one thing which you do in an ICSI, which is very important, is you would like to pick up an absolutely normal looking sperm. If you can get it in non-obstructive azoospermia, at times it is difficult. But in case you can get a normal looking sperm, a mature sperm, and you use it for ICSI, then the chances are that DFI would be very less as a cause. So it ultimately boils down to the function is if there is a poor IUI, if the patient has recurrent pregnancy failures, if the patient has poor IVF results, if there is recurrent pregnancy loss, if the man has a varicocele, if the paternal age is more, if been exposed to gonadotoxics, this is the indication for a DFI. And arrest after ICSI need not necessarily mean a poor DFI.
Thank you, sir. We would move to our next question. It's by Dr. Deshmukh. How to tease the sample of micro TC? If the sperm is immotile, should we go ahead with ICSI or not?
Now, first question, how do we tease it? So there are two ways of doing it. Either it is mechanical teasing or it is enzymatic degradation. Now, what are the different people follow different steps. A few people in the operation theater itself, in the Eppendorf tube, crush the sample and send it to the laboratory, like Dr. Peter Schegel does. That's his methodology of doing it, and his retrieval is very high. Now, once it is in the laboratory, what is normally done is it is teased by the help of two needles. And these two needles are used to tease it so as to take out the sperms and squeeze them out of every tubule. So this is mechanical method. The other method is by using an enzymatic degradation, which would degrade enzymatically the seminiferous tubules so that the sperms may come out. So these are two methods. Now, the second question, what was the second question which was asked?
Yes, sir.
No, the second question in the same.
Yeah, it says if the sperm is immotile, should we go ahead with ICSI or not?
Testicular sperms, a lot of times are immotile. And you should go ahead with ICSI in this because an immotile sperm from the testes necessarily would not mean that it is non-viable. And most of these sperms which you get out of the testes at times, especially non-obstructive azoospermia, may be immotile. Of course, if you have a motile sperm, you would love to use a motile sperm. But if it is non-motile, you can use it. One thing which we do routinely in our laboratory is use a sperm flexibility test. So when you pull it out, keep it in, pull it out, keep it in, into the needle, the sperm, the flexibility gives you an idea whether the sperm is live or not.
Okay, we have a couple of more questions. Clomiphene citrate, how much dose for how long it is effective?
I will answer this question in tomorrow's webinar.
Okay. So there is one more needle biopsy video that you showed to map the spermatogenic area. Do you do biopsy with the skin intact? Does it increase post-op pain or chances of hematoma?
See, you have not understood the concept of this. The concept of this is that when you do multiple needle biopsies, if you get sperms which are adequate to be used for ICSI, you would use these sperms. But in case you do not get sperms in the needle biopsy, you would open the area from which sperms have been retrieved if they are poor in number in the retrieval. Which means if you've taken out 16 areas, you would only enter the areas from which sperms have been retrieved if these sperms are not adequate in the retrieval to be used for ICSI or they are less. And And this whole procedure is a very simple procedure. If done well, there is no reason why you should have an hematoma.
I think that's a couple of questions that we got. And with this, we would like to conclude our session today. Thank you, sir, for the very informative and interactive sessions. I'm sure the audience are excited about it. A lot of comments are pouring in. And with this, I would like to tell our viewers again that Dr. Jindal will be coming on our platform again tomorrow with yet another exciting episode, which is the second part of male infertility, telling about medical treatments. So I would ask our viewers to join in again us tomorrow, same time. And thank you, sir, for the wonderful session.
Thank you very much. So, tomorrow we're going to have a session where I'm going to talk about the medical treatment, which is going to be the antioxidant treatment, the hormonal treatment, which is clomiphene, letrozole, HMG, HCG, whether testosterone needs to be used or not, and if it is to be used in which condition. And apart from that, I would also talk about what medication to use before sperm retrieval. And I would give you about a 15-hour, I would say, um, area in the whole lecture where I would tell you how to use gonadotropins in male infertility, where to use, where not to use. So it is something which is very useful. और एंड में ख़त्म करूँगा एक मेल फर्टिलिटी का जो पेशेंट होता है ना, जब वो एंटर करता है तो मुझको हमेशा एक शेर याद आता है, बड़ा खूबसूरत शेर है, गुलजार साहब का शेर है तो दो लाइन ही, कि लगता है आज जिंदगी कुछ खफा है। सीमन की रिपोर्ट्स उसकी बहुत सारी हो चुकी हैं, बहुत सारी, कि लगता है आज जिंदगी कुछ खफा है, चलिए छोड़िए कौन सी पहली दफा है। तो ये बड़ी खूबसूरत सी एक चीज थी, कुछ लाइन थी जो सुनाना चाह रहा था। कल ज्वाइन जरूर कीजिएगा, इट विल बी वेरी यूजफुल क्लिनिकली फॉर ऑल ऑफ यू। इट हैज बीन अ प्लेजर टू हैव यू विद अस। थैंक यू।
Thank you. Thank you so much, Dr. Jindal. And to our viewers, stay tuned to Doc Space. We'll see you tomorrow again.